My name is Liz Merkel. I am an A director of the Data Institute here at the University of San Francisco. The Data Institute sponsors all of these talks, and it is also the umbrella organization for all data science and data engineering programming and research that happens here at the university. So today we are really excited because Leo Liu is here, and he is an associate clinical professor at UCSF and a practicing hospitalist with expertise in clinical operations, research, and education. His work focuses on developing and implementing AI-driven solutions for critical healthcare challenges, enhancing decision-making and efficiency in health systems. He is a longtime practicum partner of the MSDS program. For those external guests, the practicum program is real-world work experience where the students in this room work with companies and organizations here in the Bay Area. Happy to tell you more about that if you're interested. But Leo has mentored students for over 5 years, helping them grow their machine learning skills, their professionalism, and positive teamwork. In this talk, he will explore how AI and machine learning are transforming healthcare. He's going to share insights from ongoing projects and discuss the challenges of applying AI effectively in medical settings. So, welcome so much. Join me with a round of applause, please.
Thank you for that. Just a mic check, how are we doing? Too loud? Good, perfect, all right, perfect, right. So just first things first, really just a pleasure to be here. I've been a long time practical mentor and just been such a fantastic experience. So really honored to be invited to this by the leadership, and also really happy to be able to kind of talk with all of you on a large scale about a topic that's really interesting. So that's first off. I think that the introduction covers it. I don't need to go more into it. But yeah, so I'm here to talk about applications of machine learning and AI in healthcare, right? And it's a small topic we can cover in an hour, right? And so in giving this talk, I have to figure out what is the story that I want to tell all of you, because there's so many different angles, there's so many different ways to kind of tell you what's going on in the field. And so I think what I want to do is really just give you an idea of where things are now, ideas for where things could be, so what can we move towards in terms of AI in healthcare. Some examples of personal work that I've done that I'm working on, largely in collaboration with students in this practicum in the past or present. And then maybe this is probably the most useful for you guys at the end of the day, is what are the challenges that prevent us from getting from where we are now to where we could be in the future, right? And and honestly, it's a lot of stupid stuff that you don't even think about, right? And so hopefully if you're kind of going to be building companies, going to be building products, that in the long run is probably more insightful for you than kind of some of your earlier stuff, right? So that's kind of the framing of the talk. In general, I'm going to cover these 4 main buckets: clinical care, research, medical education, and then patient education and patient navigation, right? So in general, the ideas I'll talk about being one of those 4 buckets. Having said that, honestly, feel free to interrupt me and ask questions. I don't know what you guys are interested in. I made my guess, right? I'm telling my story, but I want this to be interesting and engaging to all of you. So just stop me. It's you didn't talk about this. What do you think about that? I'm happy to answer. I'm probably more fun when I'm just kind of, just off the cuff giving responses rather than just doing a full presentation, right? So again, feel free to interrupt me. I don't mind at all. So with that, let's get started. And so, again, first section, let's talk about where we are now, right? What are we trying to do with AI in healthcare? And for that, I think, the biggest ongoing initiative is really tackling physician burnout and depression, right? Probably not what any of you imagine, right? And so, physicians have been complaining about electronic health records and documentation forever. It's inefficient. I have so many clicks. I go home and spend 3 hours writing notes, all that, right? And during COVID, it just completely exacerbated that, right? You have people who aren't used to working, people who work in pediatric patients have to take care of medicine patients. Doctors who never worked in the ED have to work in the ED, right? And just not knowing how to treat COVID, not knowing what's going on. So COVID really exacerbated physician burnout and physician depression. And a lot of people were kind of leaving the field, right? And so yes, COVID is a huge part of that, but a big driver of that was also everything that we had to do, the legal things, the documentation, all the clicks and all the orders that we had to do. And so this is a huge thing, right? All the medical organizations, CMS, identified like this is a huge priority. Our physicians are burned out, they're leaving the workforce, right? Like they're unhappy, what can we do about that? And so with generative AI, one of the biggest focuses has actually been ambient scribes. So have any of you actually seen ambient scribe? No? Okay. So essentially it's an app on your phone, and so you have this app open with you as you're, let's say, doing a clinic visit with a patient, right? So just do your visit like you normally do, you ask them how they're doing, what their symptoms are, what they need help with, you give them your recommendations, and then the ambient device is listening to all of that, like that conversation. And then after you're done with the visit, basically it uses generative AI in the background, and then generates a draft note for the physician. So the physician can go and like look through the note, like, oh yeah, let me fix this, let me fix that, and then like let me just submit the note. And so the hope is that instead of spending, let's say, 30 minutes to later in the day or at night writing that note, the physician can be like spend 5 minutes drafting the note, submit it and be done with it, right? And so there's been an explosion of kind of tech companies doing this. Like one of our fellows from my Xinran program is actually at one of these companies. And a lot of them getting traction. Any conference that you go to in medicine, whether or not that's informatics conferences or medical conferences, like ambient scribes are the kind of biggest topic of discussion. And most health systems, if they're not in the process of implementing these, they are in the process of thinking about or purchasing these products, right? So ambient scribes, a huge kind of like thing that we've seen in the field. And so do these things actually work? Yes.
So ambient scribes are currently just audio, right? They just listen to the conversation.
Yes, so the question is like ambient scribes just listen to the audio. Yeah, that's right. They just listen to the conversation.
So would there be any improvement on them also having visual on what's going on while the audio is going on, while the audio happens, or that's not?
None, I'm sure it's on your roadmap, but how feasible, how long that's gonna take, I'm not exactly sure, right? And that's like guarded stuff with each company, right? They're not gonna tell me. Although there are people I can ask, but yeah. Yeah, and so how well do these things work in general, right? So there's multiple of these kind of pilot studies out there looking at how effective ambient scribes are, and this is just one paper out of Stanford, right? So ambient artificial intelligence scribes, physician burnout perspectives on usability and documentation burden. And the results from this, from the bottom, right, so pairs of yada, 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 significantly reductions in task load and burnout, and moderately statistically significant improvements in the usability scores. Post-survey indicates favorable utility, improved perceptions of efficiency, documentation quality, and ease of use, right? And so these things work, right? They work pretty well, physicians are pretty happy with them, and by and large, like health systems like finish their pilot and they're kind of implement them at scale. And again, UCSF is implementing this at scale as well. Right? Another major example of like what are major focuses of AI in medical field right now, actually patient messages. So prior to COVID, right, you can message, you don't know this, you can message your doctor and they'll get back to you, right? And so in the past, people didn't use that as much. But then COVID hit, and then people started realizing, wait, I can message my doctor and not go in person. And guess what? They started doing that. And there was an explosion of kind of the volume of like patient messages to physicians. And like, in this study, it was like, increased by over 50%. And the thing is, right, like, that's extra work for the physician on top of COVID, on top of all the documentation burden, on top of everything else they do. And that's uncompensated work, right? They just have to stay up later in the night to do that. Like versus if you're a lawyer, you spend time on the phone with your client, you can charge per hour for that, right? And so this is another huge source of burden and another priority for health systems to solve. And so not surprisingly, like the vendor space kind of responded and leveraging generative AI to kind of create products to try to address this issue. So for example, Epic is one of the major electronic health records. I'll bring them up often. But they have a product in which they use generative AI, basically a ChatGPT model in the back end. And so when a patient messages a physician, the chatbot can read the patient's messages, draft up a potential response, and then the doctor or the nurse can read it, edit it, and then kind of officially send the response, right? And so in this study at Mayo, they were using generative AI to draft messages for patient messages. Initial pilots showed that it saved nurses around 30 seconds per message and drafts more empathetic responses, right? And they had a plan to launch this to all LPNs and nurses by mid-2024, which they estimate to save $50,000. So another major example. Other kind of use cases for generative AI that Epic is working on, right? Simplifying letters and instructions. Any of you been discharged from the hospital before? Getting some nods. Did you ever get instructions? No? Okay. Yes. Some are saying no, which is a problem. Some are saying yes. Did you understand the instructions? No. Okay. And part of that is just the doctor's busy, right? They can have 20 patients, and like they're just, I just need to get this paperwork done, right? They're not thinking about, like, they don't have time to think about, like, how can I make this as simple as possible for someone at their reading level, right? And so what if we can have generative AI take whatever we write into your discharge instructions and then simplify it to your reading level? So those are things that Epic is working on. Same thing for insurance, right? Like, don't get me started on insurance. But like, let's say I prescribe something that's denied, then we have to create forms to appeal the denial. What if we can draft that automatically? What if instead of when I see a new patient, I have to go through your chart, every single one of your notes, like one at a time, just have Epic summarize like the most pertinent information, just present that to me, and I can just read that instead of like take 30 minutes like and then coding. Or just again, just some other examples of how Epic is trying to leverage generative AI to improve physician workflow. And then the last one I will mention is probably what most of you care most about, is really predictive analytics, right? And so like in the health space, there's a lot of just like really cool predictive analytics to try to improve medical care. So some examples of that, right? So drug discovery is a huge one, right? There's so many papers out there about X, Y, and Z, building some new deep learning model that can help discover a new drug, X number of drugs, right? So there's a lot of that going on. Not my space, but very cool. The other major space is radiology, right? And so, and you know, this is an example of a chest X-ray, right? It's an X-ray of your lungs, essentially. And so these are traditionally read by radiologists. And this is just an image. And so people ask, why can't we have a AI model read this image, right? And like tell me whether or not this patient had pneumonia or not. I don't know if you know, but like, one of the former faculty here, Jeremy Howard, so he built a company, Analytic, that did just that, right? And so, yeah, there's a lot of kind of AI in terms of radiology, looking at chest X-rays, CT scan, ultrasound, any type of imaging to kind of like, give a diagnosis based on the image. And so how do these things work? They actually work really well, right? And so this is a paper looking at radiologists who don't use any AI tools to read an image versus using an AI tool to read an image versus just having the model read the image and play with it. And so in this paper, they found that unassisted radiologists had a AUC of 0.713. Radiologists who used an AI model to assist them with making diagnoses had an AUC of 0.808, so higher. Interestingly enough, and this is going to be a theme, the model itself, when making diagnoses, had an AUC of 0.957. Which is much higher than either, the doctor with the AI tool or the doctor without the AI tool. Right? So this is interesting finding. More thoughts on that later. But other, examples of predictive analytics in medicine. Honestly, if you hop on PubMed, any single clinician, some PhD or some master's student has built that model predicting X, Y, or Z condition. Right? There's models for anything. Right? Models to predict the accurate prediction of sepsis, acute kidney injury, in-hospital mortality, hypertension, right? Like anything that you can think of. And then with Epic, right? And I mention Epic so much because I think Epic is the leader in the space in terms of leveraging like technologies and AI tools at an enterprise level. And so they have a platform called Cognitive Computing, and within Cognitive Computing platform, they have 40 machine, or at least 40 machine learning models, right? And covers like all sorts of things. I just have some examples here: sepsis, deterioration, falls, acute kidney injury, readmissions, census forecasts, remain length of stay, and many, many others, right? And so, yeah, like there's a lot of predictive analytics out there. What's interesting though, and what I'm going to tell you, is that me as a physician at a major academic medical center at the cutting edge of technology and AI don't feel any of this. I don't feel any of this, right? I don't feel or see any of these tools in my day-to-day, even though there's all this exciting research. And so the question you should be asking, why is that, right? And we'll talk a little bit about that later. Okay, so, this is kind of the summary, like, this is just a highlight of where things are, and I see a little shock in your faces, like, wait a minute, all they're doing is just like trying to improve fighter efficiency, right? And that's true, and there's like several reasons for that, like, we haven't really addressed how do we use this to improve patient care, we haven't really addressed how to use this to like improve medical education. And part of it is that, medicine as a field is very conservative, right? There's a lot of doctors that, A, don't understand how these tools work. Two, even they know how to work, they don't really believe in them, right? And so they're worried that if they use these tools, they're gonna give their patients wrong advice. They're gonna, do like bad things, or they're gonna worsen disparities, right? So there's a lot of mistrust in using these tools. And so, like, the focus right now is like, let's kind of not do the more risky things that involve patient care, because that can get us in trouble, that can get the patients in trouble. And let's focus more on the low level group, right? It's really just physician efficiency, because it's, you might make even more noise, right? But you're not gonna kill anyone. Although I might wanna kill you, because people sucks, but like, I can't, right? But that's interesting. So that's kind of why where things are, where they are right now. Okay, so that's that. So let's talk about, well, what can we move towards, right? What are kind of our dream scenarios, right? And, anyone can make out some dream ideas about like some amazing product, right? That has to be somewhat grounded in reality, but I just have some kind of ideas I want to share. So one kind of idea is really just agentic automation, right? Don't just grab my notes for me, right? Like if I, when I talk to the patient and I say, we're gonna do X, Y, and Z, like make those orders automatically dependent in the system for me. And so all I do is like, yes, this looks right, and then kind of get all that sent out. If I order a CT scan or an X-ray image, like automatically schedule that, so when I know, the patient knows, the nurses know when that patient's gonna go to X-ray, and when they're gonna come back for X-ray, so I can see it back in the room again, right? And then if I order a medication, that the pharmacy has received it, that it's, it's past prior authorization, that I don't need a denial for, patient doesn't have to pay a huge amount out of pocket for. And if I change a medication, that the pharmacy knows it's been changed, I have to call them, right? So that's kind of the dream scenario for doctors, right? Just get rid of all this, like the clicking, get rid of all the paperwork, get rid of all the things have to be on phone for administrative reasons. Just let me focus on taking care of the patients, making decisions, talking to the care team, and just taking care of patients. That's a dream. There's so many reasons why that's not feasible. We'll talk about a little bit more about that then. But yeah, and I think this is feasible, right? Like with LLMs and like agents, which essentially just APIs, call different functionalities. I think this is doable. Whether or not a company like Epic can do it is a different discussion. And then just for fun, right? This is a talk about AI, so it has to be some generative AI thing. And so this is an example where just the doctor's just super happy because the robots are doing all this administrative tasks. So that is the world we want. Okay. What are some other things that I think that AI really helps us advance? So cohort discovery, right? So cohort discovery is really just epidemiology. So what is the prevalence of diabetes? What is the prevalence of heart disease? What is the prevalence of cancers in society? And the more traditional studies on which most of medicine is based on, cohort discovery is based on, does anyone know? Does anyone know at all? Not a true question. No. Claim codes, sorry?
Oh, I was just gonna say talking to the patient, asking what.
No, I mean, you can't do that at scale, right? But so it's based on claim codes, which are billing codes. Right, so, and the codes that we use are ICD-10 codes right now, right? And so what is the prevalence of diabetes? Those are determined by how many of those codes are dropped for those patients. But has anyone ever asked how good these codes are? Right, and so here's a paper covering this gap. It's a very simple paper, but it's a good one, right? So the accuracy of influenza ICD-10 code diagnosis, identifying influenza illness in children. So in children, in general, they're pretty healthy, right? It's a one problem thing. So if it's a visit for influenza, really there shouldn't be any reason why you shouldn't be putting anything else other than influenza, right? But even in that case, we found that if you're looking at IC codes to determine whether or not patients had influenza compared to actual lab tests, the sensitivity of the ICD-10 codes was around 50%. And that is, I can tell you that's true for any condition I've looked at. For sepsis, which is the space I work in, it's around 50% as well, right? And so in terms of epidemiology, if you're depending on ICD-10 codes, you're off by a magnitude of 2 potentially. Now, I will say that this is the more traditional studies. Like I will say, like the last 2 decades or so, we're not just depending on ICD codes. We're depending on clinical markers, lab values, right? So that's kind of been the next step. But again, those are not perfect, and those are not perfect because those are based on structured data. And so with the advent of generative AI, what we found is that you can use these tools to better do cohort study, right? And so this is another paper using large language models to extract complex social terms of health from visual and data-fied medical development validation study, right? And so homelessness, right, is a big concept in medicine because it's a predictor of like, how, well, A is predictor how well the patient can do, but B is predictor how much the patient can adhere to instructions and how much money they have, medications and that stuff. If you're looking at ICD-10 codes for housing instability, sensitivity is maybe 10 to 20%. Right? But if you go through the notes and have the large language models read through the notes and tell you whether or not this patient has housing instability, in this paper they said that GP4 had a recall of not 15%. And that's even better than the human attractors with a sensitivity of 0.70. And I believe that because it sucks reading notes. Like if you just imagine your day, your job is to read through 200 notes. You get tired at the end, right? Versus with these large language models, it's kind of standardized. It's they don't get tired or anything. And so from my perspective, I think large language models really change the game in terms of defining epidemiology of conditions. Because you can use notes now at scale versus before you were just stuck with structured data. And you can combine structured data with unstructured data as well. But yeah, so I think that's a very interesting area. Other things, right, this is not genius, right? Anyone would have thought this, real-time clinical decision support, right? There's so much medical literature and so much medical evidence, it's hard to keep track of everything, right? I have to keep track of medicine, I have to keep track of mathematics, I have to keep track of data science and artificial intelligence. I can't keep track of all those fields. And so I'm gonna fall behind in at least one of them in terms of most up-to-date things. But what if I can just have the information at my fingertips when I need it to help me make decisions? And that's the dream. And I think with large language models, essentially they can use as search engines to help us do that, right? And so I think that future is possible. It might not be as helpful as you think it is though, which is something else that we'll talk about. Patient education and advocacy support, right? So you get discharged from the hospital, right? The doctor's like, yeah, here's some instructions, go see a primary care doctor, right? That's usually the spiel that you get. But you're probably like, what just happened during that consultation? What am I supposed to do now, right? And you're not really sure who to call, and you call, you don't always get the right answers, or forward you to someone else. It's a frustrating experience from a kind of consumer perspective, right? But imagine that the health system kind of created a customer service kind of infrastructure where it's like, okay, I got discharged. What happened, right? And then they can have a chart that just summarizes your clinical course in really simple language, what you should do next, and if you need to make an appointment with this clinic or that person, how do you do that, right? Or if you're a patient with diabetes and want education about how to change your eating habits, your exercise habits, go through this portal and you can get that approved level of education, right? So that kind of whole interface is very possible. The reality right now is this is done very person by person, right? Literally, you're talking to a nurse, you're talking to a CNA, you're talking to a doctor about all your questions, and it's very time consuming, and it's really hard to scale. But there's parts of this that you can automate, right? You wouldn't want to automate the really concerning things, but for simple questions, how many recommendations of how I can quit smoking, part of those might be able to automate, right? And then the last thing I mentioned, better training of physicians. So manual registration for physicians, it's pretty much apprenticeship, right? It's you kind of follow the senior attending and they teach you the knowledge and you kind of emulate your style based on his or her style, right? And the issue with that is very person intensive, right? You have to be spending time with that person to learn from them. And in reality, when you're kind of working in a hospital, you don't have a lot of time to kind of learn. And so, how can we use AI to scale this up, right? And so imagine a world instead, and then I also mentioned there's a lot of variability in terms of how people teach, right? And some of the teachers that you have as a medical student might not be the best attendings, they might be your resident, who might be wonderful people, wonderful doctors, but they're so early in training and they haven't even developed everything they need to know to be a good doctor. And so how do you democratize medical training, making the best information available in the best format? And so I know that's a work that I'll talk about later. Anyway, so these are some ideas, like, what are like new realities, new futures that we can do toward using AI. And so now I'm going to go to the next section and just check I'm doing time. Okay. Which is what have I been working on, right? And there's many different examples. So the first one I'll talk about is prediction models. And so, the use case that we worked on was hospital-acquired sepsis. And so this is a project, the first project I ever did with the program here with Zachary Barnes, who's like, I cannot speak, so like, he is just so amazing. I'm so happy to have him as kind of my first practice partner. But yeah, so we worked on hospital-acquired sepsis. And this is not going to explain what sepsis is. So sepsis is basically when an infection, so for example, lung infection, urinary tract infection, skin infection, gets so bad that it gets into your bloodstream. And when that happens, your body develops a very kind of what we call systemic response, like very like exaggerated response. And essentially what it can do is it can shut down your organs, right? It basically your blood vessels become leaky, blood doesn't go to your organs anymore, and then your organs start shutting down. And so it's a bad condition. It's the number one cause of cost and number one cause of mortality, preternaturally and naturally. We decided to look at hospital-acquired sepsis specifically, right? So hospital-acquired sepsis is basically you go to the hospital, you don't have sepsis. Sometime while you're in a hospital, you develop sepsis. And then the opposite of hospital-acquired sepsis, community-acquired sepsis, basically you go to the hospital, then they get lab, they look at it, it's like, oh, you have sepsis. And the reason we focus on hospital-acquired sepsis instead of sepsis or community-acquired sepsis is that, if you have community-acquired sepsis, I can't predict that. You're kind of out there doing your own thing, and then you get to the hospital, you draw labs like, oh yeah, you have sepsis. It's more of a detection, it's not really a prediction, right? Versus when you're in a hospital, you have all that data on you. You have days of data, your vitals, your labs, like your diagnoses, your medications. And so that, I think, was the problem that we can solve. And what's interesting to me coming to this field is like most papers were looking at community-acquired sepsis, which admittedly is a bigger problem, but I looked at it as like, that's the less solvable problem. And so that's why we focus on hospital-acquired sepsis. Anyway, so hospital-acquired sepsis, subset of sepsis, accounts for 11 to 50% of cases, but compared to community-acquired sepsis, much worse mortality, much worse length of stay, much worse cost. And then the thing to know about with sepsis or hospital-acquired sepsis is that early detection is key, right? The earlier that you can figure out that this patient is developing sepsis, the earlier you start antibiotics, the better that their survival is going to be, right? And so with machine learning, like, it's a perfect tool for, I think, something like sepsis because, like, you want to make early predictions as much as possible. So that's what we set out to do. And so what were the big innovations? In interest time, I'm not going to go over like all the details, right? But I'll just highlight some of the major innovations that we did. So one innovation was just feature engineering. Right? When I started work on this, I realized most of the papers that were in this space used really, really, really simple features. What is the last blood pressure? What is the max blood pressure? What is the mid blood pressure? That's it. Right? And so how can we make more complicated features that capture the clinical insights that we see day to day as physicians and can help improve the model's performance? And so the feature included in this, so there's this standard 6 demographic feature, 12 vitals, and then 44 lab results. 44 lab results sounds like a lot, but actually for example, a CBC or complete blood count has like 10 components, right? So this is really just the most common labs and vitals that you will see in any hospital setting. And what we did that was interesting is that we created time-weighted features. So we look at the lab values and we evaluate them at different time windows. So for example, 24 hours, 48 hours, 72 hours, and 120 hours. And we would take aggregate measures during those time windows. For example, min-max mean means variation. We'll look at trend features, which is the slope, the monotonicity, min-max difference. And we also create derived features. Derived features is essentially just combining other raw features into clinical concepts that we look at as physicians. And like you guys might know that because you're not physicians, right? So for example, shock index is your, let me make sure that's right, it's your heart rate divided by your systolic blood pressure. Pulse pressure is your systolic blood pressure minus your diastolic blood pressure. PaO2 or FiO2 just to measure how well you're breathing, and just some examples. And the reason this is pertinent, like, these are things that we look at as clinicians, and I realized weren't really captured in the machine learning models. And beyond that, we also looked at other things like level of confidence per patient, number of nursing observations, just getting a sense of how concerned nurses might be about a patient, and whether or not blood cultures were. Yes.
And you're saying that these were things that you as physicians looked at, but weren't being looked at in machine learning models. You mean by like people who were writing up papers in regards to machine learning models? Who was not utilizing the derived features?
Yeah, so the question is like, who was using simple features and not more complicated features? At that time, pretty much any paper I read, right? Min-max to the first class.
So I would expect people writing papers would talk to like field experts, like physicians, which is that overlooked.
No, so this gets to another point, right? Like, if you take an expert physician, you take an expert data science, just put them in a room, can they create the best model ever? Right? And the answer is probably not, because like I've had these conversations with physicians, and like you're trying to talk data, you're trying to talk data science to them, and like they don't know how to process what you're saying. They don't know how to answer the questions in a way that's most effective, right? And so like that's been one of my theorems, is that like you need someone in that room who can speak both languages well. Right? And my guess is like, I don't know, like if you have the best physician in the world, but they might not realize that creating a feature is powerful for machine learning. Now, has the field progressed since I've done this? Yes, right? But I still don't think that, I haven't seen papers been as advanced in terms of like feature engineering as we had in this, right? Now, some of you are probably saying, oh, this guy's like old school. In the future, we'll just kind of automate this. And that's very possible. I know that's what machine learning scientists do. They try to automate away the expertise. As of right now, I still think there's value in clinician kind of insight into these machine learning methods. But anyway. And so the results. And so the best model that we got was the XGBoost model. And then the validation AURC was around 0.96. The validation said AUPR is around 0.51. And then on the test set, most encouragingly, the test set AURC is 0.95, and the test set AUPR is 0.84. So pretty good results, right? Again, sepsis is hospital sepsis is a very low prevalence condition, anywhere between 5 to 7% depending on your institution. And so for that, to get this level of like RC, AUPR was like very good, and like definitely matching the state of art. And I also wanted to ask, well, like what was the added value of the all feature engineering I did? And so we did create a model that just included raw features and none of the engineered features. And you can see the thing that I cared most about, the test AUPR really helped substantially, right? And so I would argue like this expert-based feature engineering really did improve it. Here's the feature and fermentation importance. I know there's other, but I just have feature fermentation because that's the quickest thing I can find. Obviously there's methods. Normally when I look at papers and look at the features, there's usually one or two that I'm like, yeah, I don't think that really contributes to what you're predicting. But when I saw this list, I was like, oh, I think we actually have something here. Because every single feature on here is something that I look for as a clinician in terms of determining whether or not they've been sick or not. Right? So oxygen delivery, their platelet count, how long they've been in the hospital, bilirubin, and then if you go up, like if you go around here, you start seeing some variety. What is the max temperature in the last 48 hours? What is the standard deviation to respiratory rate in the last 24 hours? What is the max platelet count in the last 120 hours? Right? And so you're seeing those kind of pop up on the feature, which is good. But I mean, the other thing we did from this work is really, I think at that time people were arguing that these things are black boxes, and I'm trying to make like not really. It kind of depends on what model you use. And one of the benefits of tree-based models is that they're very explainable, right? And so this is just using the line library, and just like to show that for this patient at this hour, this model predicted with a 0.96 risk score that this patient had hospital-acquired sepsis. And it could kind of show why it said that, right? And so it said that because the serum lactate was above 1.6, 2.7. The patient got blood culture within the last 24 hours. The serum immature granulocyte, which is a marker of infection, is high. And then the serum white blood count was also high at 21, right? And these are all things that I look for as a clinician. So I look at this like, yeah, like this thing's kind of reading my mind, which is awesome. So that all sounds great, but I think the second major innovation out of this work is like when I look at this, right, all these papers, all the comparing this there, what is the AURC, right? What is the F1 score, right? Like what is the whatever? But as a clinician, I couldn't translate that to how good the model will be in terms of clinical utility. Is this actually going to help me solve my problem? Right? I can't translate that. And so I realized the bigger problem is how do we translate a metric like AURC to things that we actually care about as physicians, that show how effective these tools are actually being in helping us solve our problems. And so what are some examples of that? So what we did is we took my original model that Bill was at, and then we improved the model with the UCSF health AI team, and then we validated it on retrospective data. And we compared it to current state, which are called best practice advisories or BPA. It's basically just rule-based like early warning systems, right? And so as you can see the performance and sensitivity between and positive predictive value between the BPAs and the machine learning model. And you guys know you can set the threshold whatever you want. So if you set the machine learning model at a threshold of like 80% sensitivity, you get a positive predictive value of 0.25. The BPAs in comparison, I wrote is less than 50% sensitive. There's a reason I did that because I don't want you to show you the real number, right? That's what I'm gonna say. Right, but versus you can get the machine learning model with sensitivity 80% or 90% with a higher positive value, right? So at a minimum, like if you're building a model, you should be reporting those level type of metrics. But let's take a step beyond that, right? And so I told you before, like the whole point of these early warning systems is to let the physician know, hey, your patient's going to develop sepsis in the next day or the next few days. You should drop whatever you're doing, evaluate them, maybe give them some antibiotics, maybe give them some fluids. So how good are these models at actually doing that? And sensitivity doesn't really tell you that, right? Because the patient, the alert can go off on the first day, but the patient doesn't get sepsis until day 10. And from a sensitivity perspective, that will count as a positive, even though from a clinical utility perspective, that's zero, right? Like 10 days in advance, doesn't mean anything to me. And so we asked then, like, well, how do these models compare to the BPA in that critical period before sepsis occurs, in that time where it makes sense for the physician to actually evaluate the patient and start treatments, right? And so basically, what is the sensitivity within 72 hours of sepsis onset? For BPA, it was 39% sensitive, and then for machine learning model, it was around 7% sensitive for first alerts, and then for any alert, it was 80% versus around 50%. And then what about antibiotics, right? So antibiotics is the main treatment for sepsis, and your alert happens after the patient already got antibiotics. Doesn't really help, right? And so let me finish this point and I'll get back to it. And so we asked, well, like, what percentage of these alerts actually occurred before the patient first got antibiotics, right? And so within that critical 72-hour period, it was only 35% for the BPA alerts. It was like around 60% for the machine learning alerts. And you're talking about ever, right? Like not just within 72 hours, it's 54% for rule-based alerts and then around 80% for the yes.
So if the course of treatment for this alert going off is to give the patient antibiotics, wouldn't from the machine learning model's perspective, like just telling every patient to give them antibiotics would result in nobody getting sepsis? Like, wouldn't that be a little like the wrong time?
Well, there's also the flip side, which is like you don't want to give everyone antibiotics because there's consequences of that, right? For the antibiotics themselves, like they can damage your kidneys, they can cause autoimmune reactions. But then there's the bigger idea of like you give everyone antibiotics, you're going to cause super resistant bugs, basically. And so it's a cost benefit. You're right. Like, why doesn't everyone get antibiotics and go in the hospital? And like, yeah, you could, but like that's like in the long run, it's going to cause a lot of issues.
But it seems like it could still end up gravitating for that. If say for the first year, like you adopt this and it says, okay, this person's going to get has a high likelihood of sepsis, give them antibiotics. And it does that for all the patients who get sepsis, to the point where nobody does get sepsis, and then it doesn't know if it was actually right or not, and then to know this patient got sepsis in your training data.
No, totally. That's a good question. Like, how do you update when the models are influencing the behaviors, right? And I don't know the answer to what's the best way you can update and retrain your model, right? And that's one of the things we're going to figure out when we get there. But like, all valid points. And then, and I mentioned before, like the goal is to have these alerts before the patient gets septic, before they get antibiotics. So what is the lead time? And so the median and the mean lead time for you can see at the bottom For some reason, I forgot to include DKR, but just believe me, it's more than right? So this is what I mean by example of like translating the more machine learning data science metrics, the ones that actually have impact, so that we can more systemically measure and compare different machine learning models. And where we are with this work right now is that we are, so it's in silent study, we're comparing my machine learning model to Epic's machine learning model head-to-head, right? And so we're gonna see which one performs better using metrics, like more advanced metrics, what I term safer care metrics. And hopefully it might substantially better, you might be able to implement that at a health system level. And so that's not the only machine learning model I built, like other ones that I've built and working on. So we built a recognition one, that was with Amanda Liu, worked with me several years ago. And then this one's in hold, but the health system is actually evaluating ethics readmission model. And the early signal is that it's not performing the way that we would want to, and there might be discussions about implementing my model, or testing my model at least. Another one's kind of remaining like the stay, and it's something we're having ongoing conversations about implementing at the health system. So that's predictive analytics. The second major category of things I'm working on are chatbots. And so I built several chatbots. The one I'm going to show you guys today is called an ID curbside chatbot. And what this is a RAG-based chatbot, right? And all it does is it uses de-identified infectious disease nodes from UCSF. So that is the database. And essentially what the chatbot is doing, if you answer the question, it is telling you what UCSF ID recommends on average in the past for a similar case, right? And so let me give you guys a demo of this. Sorry, I'm not a Mac person. I'm not really usually on Mac, so if I download it so smooth, that's fine. You able to see this? Yeah, so this is the RAG, and I don't know, someone give me an infectious disease question.
I have a rash underneath my armpit.
Well, it's not an infectious disease question, that's a dermatology question.
Oh, okay. Yeah, yes.
Ask it about COVID.
So, okay, what do you want? You want how to treat severe COVID? How do you treat?
How long should we isolate with symptoms or something like that?
Okay. How
Feels topical.
long should you isolate if you have mild to moderate COVID? I'm not sure how well this is going to do with this because it's like an application use case. It's more like an inpatient chatbot, but let's see. Yeah. So it's thinking.
GPT-4.
Yeah, 4L, right? Yeah. Now we're 4L, we're fancy. Come on. Think that's great.
It's going. It's going.
Well, maybe I won't see too many of these examples. It's going to take a long to change things.
I think the idea is by the time it's done, with the query, you're no longer interested. It just waits for like 7 days.
Okay, so we have runtime issues, right?
That's gonna be like,
Is it going for runtime issues?
Sick.
Might not. That's it.
You check the logs, like.
Let's give it another minute. If it doesn't work, then we're just going to respond.
This website.
Yeah. Well, we don't do COVID anymore, so that's why.
Okay. Well, maybe we can just
Access
like,
forbidden.
is the internet? Is you guys? I think I'll assume
Actually, I get laid off.
well, anyway, well, let's see if it's running. But the general testing that I've done with this, like, it's spot on, right? Like, it's pretty visual, and then the other nice thing that this thing does is it actually spits out, these are the notes I got this information from. So you as a physician can go like, look at these notes and validate, oh, this is like the same question that I had, and like, what this is saying is actually confirmed to me. We'll come back to this is working later, but anyway, fun with live demos right next. Okay, so, so a tool like this, right, there's a lot of clinical implications. Like, can I use it as hospital? Should I use it instead of infectious disease doctor? Do I just use it to kind of like give me advice? Like, what are the clinical implications for using it? Educationally, should we be using it to teach our medical students, residents, should we be using it before they ask me questions, right? There's a lot of implications there. There's also business implications. It's because this is UCSF IP. And this can be a product that can be sold to other hospitals, to other countries, right? And so there's a lot of cool implications for this, and we're still figuring out what exactly we're doing with this. And then I mentioned before, kind of working on the education space, so something else that we build is a diagnostic reasoning chatbot, right? And so the goal, again, is to try to democratize the teaching of like kind of just the best possible clinical teaching to as many residents and medical students as possible. And so what it is, again, it's a RAG-based chatbot. The data set we use are what we call high-quality clinical solving problem cases. And so these are cases which, like, there's a patient presentation, you give it to an expert doctor kind of just like says everything that he's thinking in terms of how he approach a case, what's going on, what's the differential diagnosis, what's the ultimate diagnosis, and so really advanced. And so, like, we use that as the underlying data. And so the idea is that if you're a student and you're working on a case, you can put in your case, what you're thinking, and then the chatbot can give you like mentoring, like, this is, I see how you're thinking about this. I think about asking this question. This is how a narrative differential. And so we're trying to see if that can be a way to kind of improve identification. And then, both Dominic and Victoria, who are sitting back there, they're both kind of working on me. We're not just trying to RAG-based approach, we're also trying to fine-tuning approach as well for this. And then the last thing I'll mention is really just augmented sharpening process. So the thing I will tell you about healthcare, you'll be amazed how much of what we do is finance, right? So Department of Quality, Department of Population Health, determining when our patient is eligible for X, Y, Z, determining where we should put them in X program, Y program, want that. A lot of that is done by chart, right? It's a very manual and time-intensive process. And so the Office of Population Health basically came to me and asked, like, hey, is there anything that we can do to help us streamline our process, right? We have all these patients that we decide whether or not they're eligible for certain programs that Population Health offers, and we have all these very specific inclusion criteria and exclusion criteria, right? And it takes us forever to review these. It takes us so many people, and there's also a lot of variability in terms of what people say when they review these. Because again, it's not the most fun thing to do, right? And people getting tired or just like feel like they want to make X, Y, and Z decision on that day. And so can we help them streamline that? And so what my team is we built a prompt, right? So we built a prompt that can read through all the notes for a patient and help them determine whether or not the patient is eligible for their program. And so essentially it's a chain of thought prompt, right? So the first task was really just asking the chatbot questions about the patient. Does this patient have X, Y, Z condition? Does this patient, were they admitted more than 2 times in the last year? Whatever, right? So just really just getting chatbot to answer questions about the patient. Task 2 was based on the answers above, then asked, does the patient meet certain inclusion or exclusion criteria for each of those criteria? Then task 3, just summarize it, right? So based on your answers for task 2, tell me, make an overall recommendation. Is this patient eligible for X, Y, Z program? And not just give me that, but actually list out the reasoning, okay? And so you can actually see that reasoning. And so we built that pilot, and so this is kind of just the confusion matrix of like how well that did. Technically, we got sensitivity around 80%. However, while doing this, we learned that the 3 false negatives, it turns out that when we reviewed those patient charts, we thought those patients should be eligible. Should be ineligible, right? And so we're actually going back to the population health team and saying, hey, we think these patients should be ineligible, but like you're telling us they're eligible. Like, what is the actual answer? And so we're going back and reviewing that. And again, there's just highlighting some of the variability in terms of how people make decisions, how people chart review, right? And so we're also helping us standardize the process. But otherwise, we're kind of in the process of really automating this now, right? Building this as an API, putting in the business production and validating at a higher scale to see if we can streamline how they do their kind of systems. And really anything in healthcare that's done by chart review now, you can think about using generative AI as either replace or supplant that or assist with that process. Okay, so those are some examples of things that I'm working on in this space. And then the last part of my talk is really, talking to people about like what are some barriers and challenges to doing all this, right? And so the biggest challenge I'll tell you is that the biggest issues aren't technical, right? So I said before, I would love, so when I write a prescription, automatically know whether or not that prescription is covered by insurance. If it's not covered, what are medications that I should, try instead, right? Instead of me sending it a week later telling me it's ineligible, patient didn't get their med, I have to call like their office for 2 hours to get someone to talk to me to like give them a denial, like a appeal to the denial, and then that takes 7 days for some. It's just such a terrible process, right? There's no reason that should be automated. We had the technology to make it automated decades ago, right? But for whatever reason, in our healthcare system and society, we decided it's not in our prioritization to build those interfaces and make that possible, right? That is not a technical issue. That is a system policy issue. And so technology is not going to solve that. So that's one of the biggest challenges now. The second, another real challenge is that the financial incentives decrease the impact of predictive analytics. And so in healthcare, the majority of hospitals operate by a fee-for-service model. Has anyone heard of fee-for-service? Not really. So fee-for-service is basically the hospital makes money when they see more patients. When they make more money when they do more procedures, right? And stuff like that. And so if you are a patient with diabetes and your diabetes gets really bad, you got a really bad ulcer in your foot and you have to have your foot amputated, right? I mean, the fact that we have to amputate your foot, like that's a procedure, right? That should generate more revenue for health system. Now, I'm not saying like doctors are trying to like, trying to say like not control diabetes. Like we are trying like, please control your diabetes. But like when you're making a decision, am I gonna, hire another plastic surgeon that can make me, I don't know, X, Y, and Z amount of revenue versus hire a care coordinator who reaches out to you. It's like, hey, you didn't come and see us about your diabetes in 2 years. You really need to come in. So those are the decisions that get made, and the current model is really incentivized by kind of just seeing more patients doing this, right? And so in that framework, predictive analytics doesn't really help you because it doesn't really help you see more patients. What helps you see more patients? Having more doctors, right? And so, for predictive analytics to really shine, you really have an environment where you incentivize to care for the population, to help your population, right? And so, that's why accountable care organizations, that's why integrated health systems like Kaiser exist. So how they work is that they get paid a certain amount per person that they take care of, right? And if they spend less money per year taking care of those patients, keeping them healthy, they make money. But if they do a bad job of that, they lose money. And so they're really incentivized there, like, are your vaccines up to date? Did you come in for diabetes? Just constantly hammering on these things because that is the target kind of business case, right? And so in that case, predictive analytics framework, you want to know where are they develop diabetes, who's going to develop hypertension, how do we get them before they even get these conditions worse, right? And so financial incentives are not aligned. This is a big one. Of all the AI tools that we have, I mentioned before that all this cool stuff, I really don't see it in my day-to-day. And that's because they really have unclear ROI. And then I'll say good predictions and good information does not always equal utility. You need something for that. So, Epic's model, I told you to have a machine learning sepsis model. But when you take their model and validate it, right, it turns out you're not really sure it works that well. So this is a paper, external validation of widely implemented proprietary sepsis prediction model in hospitalized patients. And they found that the Epic model had a AUC of 0.63. I think they're cited the paper originally when it was around 0.8, right? And so when they do external validation, performance is actually much lower than what Epic is, right? And so in general, when you take any machine learning model, it sounds awesome. Oh yeah, but AUC is great, and you do external validation, it tends to not work as well. And part of that is just the data is different in all these different health systems. And so when you're taking data making one system to another one, you're going to have data shift trip, you're going to have different populations, so they're not good. Another example of ROI. So I talked about AI graphics. And so do they actually improve clinical documentation efficiency in the long term? And so this is a longitudinal study, and what this study found is that after controlling for length of intervention, age, gender, provider type, years of experience, based on outcome, we did not find statistical significance in the primary analyses of EHR and financial metrics in terms of using ambulance drugs, right? And so, we have all these early papers showing us that people like ambulance drives and they're making it more efficient. But why is that? Because these are all the early testers who love technology, super excited to try this stuff, super excited to make it successful, right? But when you're trying to give this technology to doctors, I don't care about technology, I don't want to use it soon, you're not going to get that same level of result. And so what we're starting to see with these ambient stress systems is that they don't really, they make us happier, definitely, we're not sure to make us more efficient. They definitely don't make us more efficient to see more patients. So end of the day, they're a cost to make us happier. And so for health systems, you have to look at that like, well, is that worth it? Right? Yeah, you think it is, but I'll talk about why that's a hard decision. The other thing I'll say is the good predictions is not full clinical utility. So let me give you an example of that. Mortality prediction, right? I'm going to discharge a patient, model tells me this patient's has a mortality of like 90%. Is that going to change my behavior? Most of the time, no. Like, yeah, this is a really sick patient. They have terminal cancer. There's nothing I can do to fix that. That's not going to change my behavior, right? And so if you're trying to predict an outcome that we can't do anything for, then it's not going to be helpful. Same thing with risk of dementia, right? I will say this is a little bit different. We are starting to have more interventions for decreased risk of dementia, but prior we didn't. So if you're predicting you're going to get dementia, then sorry, that just makes you affect the such questions. Oh, sorry, don't forget that. And then the other thing I will say, this paper Ray asked, we have these tools to give us good information at our fingertips, but does actually make us make better decisions? And so this paper was comparing what a doctor using a large language model to help make diagnosis versus the doctor alone. And the hypothesis is that the doctor with AI should be better than the doctor alone. But in the study, what we actually found is that the availability of a large language model to physicians as a diagnostic aid did not significantly improve mental reasoning compared to conventional resources that are alone, demonstrated higher performance from both physician groups, which is what we saw in prior COVID, right? And again, like, why is this, right? Because, like, again, part of it is that maybe we don't know how to use these tools in synergy. Part of it is that these tools might just be an added burden every day we have to see, right? Like, to tell you what the life of a physician is, I am a constant data machine. I am constantly seeing data, right, from the computer, from the nurses, from the patient, and I'm constantly making decisions. And if you're going to introduce more tools and more information after the process, like, that not necessarily makes me better. That is like testing. And then I guess I should cover this. And so healthcare, right? There's all these companies that like, oh, hey, the startups like, hey, you should try our pilot. It's really cheap. Like, you should buy it. That'll be really good, right? And I feel so bad for these companies because I know like none of them are going to get any money the next, right? And part of that is we don't really have a lot of money, right? Like, if you look back a couple years ago, 2 out of 5 hospitals that are losing money, and we're generating kind of low margins, like business. And so we don't have the money to throw around. The money we do throw around are for like essential services. And it's very rare where we kind of like make pretty large capital expenditures, right? So like, from COVID, for telemedicine, with COVID, with the ambient drive, and with electronic health records, those are the major things. But outside of that, it's really hard to get hospitals to take the view. I'll kind of skip this. If you ever want to visit Epic, it's actually a really cool campus. It's like, Harry Potter books. And then trust and bias, right? And so, yeah, like we all know these machine learning algorithms are biased. So this is like early on in ChatGPT, he asked you to generate an image of a white piece. This is what you get. Right? So these things are tremendously biased. And so one of the, the Hippocratic rule by physicians do no harm. And so when we see images like this, like, well, like these things are really biased, so they can make the care of our patients worse. They might make disparities worse. Physicians are really kind of like, I don't know if I should be in these things, right? And then, and not just like, the bias itself, but also the hallucinations. I know hallucinations are not as bad now as they were before, but like physicians are fixated on hallucinations and bias in these models. And so that really decreases trust. And we all ask ourselves, should we improve this? Like, are actually making better than this? Even though objectively, I think, like they're actually pretty good. But anyway, let me just stop there. It's been a long time, but maybe all of us might get it in a nutshell and have answered questions.
Back when you were talking about having physicians and AI together versus just physicians in terms of performance or whatever, is that looking at all physicians, or have you ever looked at just like what physicians are some and you can't figure out what is wrong with the patient? Does AI help there for bringing in their expertise?
I don't, off the top of my head, I haven't seen that exact scenario. So the question was like, have we looked at not just like all the cases that a physician reviews, but only like the really hard cases. And I haven't kind of seen studies specifically on that, although it's very possible there are. I will say that in my experience, I've seen that the large language models actually perform worse on harder cases. And so for harder cases, that's better to just go with physicians. But I think like at the easier cases, in general, the machine learning models do like much better.
Hi, thank you so much for your time. So you talked a lot about like what you called out earlier, like productivity based like things like physician side rather than patient side. And so like we talked about like the auto transcribers and like doing charting automatically and stuff like that, right? With the medical billing thing. And like a lot of those problems are systemic issues, like you talked about, like, and a lot of those are localized to like American healthcare. So if we have like physicians that are too busy and nurses are too busy and they're overloaded because they're working for like private hospitals, right, or for-profit hospitals, and they're playing the denial claims game with like United Healthcare, the recent thing with this, and medical billing codes historically have been a tug of war already, right? With like changing classifications to like whatever, right? Like how, and then this idea of like pilot programs and all this data, like where is the patient in this, right? Because it's like, as like someone who benefits a lot from like medical care, like bedside manner, like the human touch is like so important. And it's really easy for like an anxious person like me to read like a discharge chart or something like that, or the notes, and just go on the internet and like I'm dying, right? And it's like so it's like right, so it's like if there's no if the doctor's too busy and they have to use these tools, if the nurses are too busy, if these claims are being denied and then challenged and then denied again automatically, and I'm getting like a chatbot interaction, like how am I doing as a patient in all this? Like where's
It's a great question, right? And I think we're struggling to answer that. We're struggling, what does that mean future for the patient, right? And then part of that's we don't know what's safe to do, right? And largely, I guess we don't even fully understand what patients want to do. I think in general, I flew through this, but like in general, I think patients say they don't want AI to treat them, right? There's still, as you said, the human connection. And I didn't get to say this, right? But like, like there's people who make this claim that doctors will be obsolete. And I was like, no, I'm not even worried. I don't lose sleep over it, right? Because like, you at the end of the day, like you still have you have that connection with that patient, but to sit down with them and tell them sometimes very terrible news. And I just don't ever see people accepting that. That's going to be a good lot.
I have a quick follow-up to that also with the idea of removing like the human element from the care side. Historically, like there's a large bias towards like cis white male diagnosis in medical literature. And as time's gone on, it's like improved because of awareness. You talked a little bit about bias. How are we, but how do you prevent, like underserved populations being swept under the rug in these scenarios in a sort of like automatic way, and then there's nobody there in front of that person to see what's going on?
No, and so it's a tremendous problem, right? But I can say at least for AI, predictive machine learning models, the standard is that you want to evaluate them across like at a minimum. I'm not saying this is the right answer, right? Or the best answer, but you want to like evaluate the performance of your model across different ethnicities, different social dynamic groups, different gender, to make sure your model is like not like super underperforming one specific group. And if you are, it is a one specific group not doing well, maybe you change your question there, right? Or maybe you say like, like, so there are ways that you can get across that.
Okay, thank you.
First.
Let's see. Your talk was great. My question is about AI when it comes to both the doctor side and the patient side and its integration in a lot of these healthcare provider systems. So I know systems, like legacy systems, like they haven't been updated in many years. Eventually, like
Since they started.
Cost, how many records there are. But how do you navigate things like that where a lot of the modern softwares are moving on the RAG chatbot or talking to the patient or for helping the doctor as hurting. How do you navigate trying to go in the old software that is currently being used by so many
I had a couple slides that I flew over, but I'm glad you asked, so I can kind of cover that a little bit, right? I think the reality is that, like, so Epic and Cerner, like, the cost of implementing one of these any of these systems or health systems, hundreds of millions to $1 billion. And you're absolutely right that these systems are not built for the AI age, right? Like they what they're really good at is really good at attacking billing charges. And you build the clinical application on top of just kind of a financial billing essentially, right? And so yeah, Epic, I showed you Epic does a lot of cool stuff, and they are Google, they're not like Meta, right? In terms of the harm engineers, the complexity of the models, the models they give you are very simple, right? Like you don't have a lot of customization. You're very limited in terms of what to do, like how you kind of check thresholds, right? And so that's the challenge in that, like, the companies that we have, while they're trying to move in that direction, they're probably not as advanced as some of the best companies, technology companies, to kind of bring us to the next stage. So the question is like, well, why can't we have innovators? Why can't we just start a company with a health record? And the answer to that is that the barrier to entry is $200 million to let a good value then help figure out system. And so you have to convince the health system that your EHR product is worth losing that kind of instrument. So the risk is, like, why do we even get all these EHRs? At least the government basically said, here, I'm giving you money, I'm giving millions of dollars to establish EHRs, and kind of this is where we are now. And so would it require another invention like that to spur innovation and growth in different vendor systems, right? And so I guess the question is how much is yeah, we complain about certain products. They're not advanced, and you do things like it's a different person to company out much more leverage for advanced AI technology that would be better. But can they make that business case to survive? It's very difficult.
This is very interesting. You've talked a lot about some like the cultural barriers in a lot of these models. It's item culture. Do you think maybe one great product will slowly convince like invested hospitals to adopt it, or if it would pay pretty slowly to benefit the one that's in there? They not our standards in the beginning that's the fashion people implement
No, it's just a question. And I guess it's like, do you regulate, right? Do you just say to the government, hey, doctor, you have to use that kind of product? My guess is we won't get there, right? I don't see the tools that we have that much better than physicians to like be able to kind of justify that in that. I feel like we just haven't seen that killer app. Like none of us have seen that. Like, ambient drive is kind of close, right? People are excited about ambient drive, but now that like this currently starts in mass, people are starting to see some limitations that it's not as good as they are as a large scale, right? But I don't know, maybe it's technology gets better, and maybe that is that kind of like that killer app, right? So like yeah, we just haven't seen a killer prediction model, for example, like this thing's always right, this thing's being money, right? And how we do that. And part of it is actually not the model itself, it's in engineering, right? So, but the hospital health system that I worked at, it's complicated. I won't go into details of it, but they had a radiology model. I was like, oh, cool, let me check it out. And like, probably like, yeah, I didn't know it. Right? So just like the engineering of actually setting up a health system. Again, healthcare system might not have good IT, just like they don't.
Right. On that, I don't know if it was such a happy note.
Healthcare is very happy.
Yeah, I mean, thank God for healthcare and its improvements and individuals like you who are working towards that goal. So, thank you so much.